Well, hello there. Good afternoon. Guess what time it is? Top of the hour, 4 o'clock in the Mountain Time, which means East Coast, 6 o'clock. It's 3 o'clock on the West Coast. There's only one place that you should be this afternoon, and that is Fertility with Fink Friends right here. My name is Dr. Randy Fink, and I'm the clinical director of IVF services here at CNY Fertility in Colorado Springs, beautiful Colorado Springs, where it's 73 degrees this afternoon. And as always, here we are for Fink and Friends. We've got a bunch of different feeds. Why, we've got CNY's Instagram right here. We've got YouTube, Facebook, LinkedIn right here. We've got my Instagram here. And we have a very special guest over here on the side who is going to be our guest today on Fink and Friends. Normally I say I am Fink, you are friends. But joining me in the office studio today will be none other than Brandis Montez, our nurse practitioner here in Colorado Springs, and we'll invite her in just a moment. But let's start by saying hello to all of our friends. What's going on out there in your world? You know, this week has been Gosh, there was no sound over there, so you missed the the entire part, and that would be because I forgot to plug in that microphone there. So what I said was, hi, Randy Fink here, Fertility with Fink and Friends, and a special shout out there to my mother in beautiful Mobile, Alabama. Glad to see everybody here today. Sorry we had a little issue there with the audio on my Instagram and lost a bunch of people as a result of it. We've got CNY, we've got Instagram, and Brandis's Instagram. Brandis Montez will be joining us in the studio today, but I started by saying, let me say hello to all the friends joining us here. First up was Katie SK. You were number one on the CNY Instagram to join. Hi to Leah. I'm glad to see you as always. Brianna's here. Hi from California to Ariel. Thank you for being here. It's Jen. Good to see you. Boss Steph from Massachusetts. Oh, we're very flattered to have you guys here. Hey, Kayla, good to see you. Steph has her first appointment on May the 9th, and we are excited to have you with us as well. Hey, Molly, Erica's here, David's here. And let's see, Ariel had a hysteroscopy today, so that's a good way to make sure everything is good on the inside. Hey to Florida, babe. What does that say? Homes with Mar, it looks like. Oh my gosh, the miracle baby you helped us create is walking today. Oh man, that is truly, truly awesome news. Let's see. Sorry about not being able to hear me there before, but Amy says, am I the only one who can't hear? And it was entirely my fault there. Sorry about that. Hey to Jody Hoffman. Andre is with us. Amy is in Colorado now, and will see us Thursday morning for the first egg retrieval. And over here on Brandis's, I can't quite see it, but we'll say hello to you guys in just a minute. You know, without further ado, let me introduce someone who I work with very closely on a day-by-day basis here. Brandis is an extremely talented nurse practitioner, is very wonderful at what she does, not only with outreach here at CNY, but with the patient care, with doing egg retrievals and embryo transfers. Really, we are very, very lucky to have her with us, Brandis. Welcome. Thank you so much for being here today.
Hi, guys.
So, you know what we're going to try to do, I started to say it's been kind of a big week with bad weather in the Midwest. And so, our thoughts go out to the folks in Oklahoma and down south who are dealing with all the tornadoes and stuff. And so certainly everybody here, our thoughts are definitely with you. Hello to Zenaida in Miami. A special hi to you. Okay, well, you know what we're going to try to do is we're going to try to get to as many of the questions as we can today. You'll get to hear it from two different sources, not just from me, but Brandis will help to answer some questions. And before we do that, I think Brandis, people are. There are many people who may not know what a nurse practitioner is, what your training is. What brought you, what is a nurse practitioner, and what brought you to CNY?
Yeah, so a nurse practitioner is an advanced practice provider. So it's a registered nurse that essentially worked as a nurse for a while, and now I don't think that's a requirement anymore, but you worked as a nurse for a while. You go back to school, you do advanced training, and then you have clinicals to where you train on the job. You can prescribe medications, you can do procedures, basically a lot of things that a doctor can do. I do new patient consults. Really, kind of, we do a lot of similar things. It kind of depends what state you're in. So some states require a doctor's supervision. Colorado does not. So I am an independent provider. And as far as what brought me to CNY, a lot of you know that I did used to work orthopedic trauma, and I had a friend who had a friend that worked here, and they were looking for a nurse practitioner, and this was not a field that I at all thought I would end up in. But I did, and I'm really glad I did, because I can't imagine ever working anywhere else or really in any other field. So I'm glad to be here.
I think maybe one of the biggest, so Brandis worked in orthopedic trauma. So she was dealing with people who had had some sort of problem that brought them into a trauma center, accidents, gunshots, all those things that involved orthopedic injuries. And while I know you had clinic hours, you would see some of these people in follow-up. It must be very rewarding here to be able to see people maybe from the beginning of a consult through their stimulation, doing an egg retrieval, doing their transfer, and then getting those wonderful baby pictures.
Yeah, that is the cool part. And, here it's a little different because we don't always get to see patients all the way through. Sometimes we do if you're a local patient. Sometimes you have patients that are kind of global patients that travel. But I think Instagram has been a big thing that has been able to help us to kind of follow patients through their journey. A lot of you send me your baby pictures. I'm kind of behind on my messages right now, so I haven't seen all of them, but a lot of you send me your positive pregnancy test, which is really cool in this job because I don't get pictures of people's x-rays on Instagram.
Of their broken bones or the
arms.
pins in their knees and their ankles.
This is cooler.
That's awesome. A special shout out going to all our friends on Instagram, or rather on Facebook. 25 folks with us on Facebook. Hey to Ethan and Michelle. Michelle asks, how common is pregnancy in the first round of IVF? You want to take that one?
Sure. This is very dependent on so many things. It's dependent on your age, because age is the biggest predictor of really fertility, age of the person with the eggs. AMH, or your anti-Mullerian hormone, which gives us an idea of your egg reserve, and then anything else that may be adding to it, whether that be endometriosis, adenomyosis, different factors. But typically, under the age of 35 or 35 and younger, with a normal AMH, if we can get a good amount of eggs, the chance of live birth from, if you're able to grow those embryos to blast, which is day 5, 6, or 7, the chance of live birth per embryo is about 40%. So, the more embryos or the more eggs we can get, the higher the chances of, we're going to get a normal embryo that results in pregnancy. So it just kind of depends on age, your AMH. So, and also your family goals. If you want one child, that may only take you one round. If you want multiple, it may take multiple. So that's kind of a hard question to answer generally, but that's a good question to ask in your consult if you have one coming up.
Absolutely. So do people get pregnant in their first round of IVF? Absolutely. Yes, they do. Rachel's over here on Facebook as well. They came to Colorado for the first embryo transfer in March, and you are 9 weeks on Friday.
That's
God,
awesome.
we love to hear those stories. That is just awesome. Crystal is here on the Instagram side, and May 5th transfer unfortunately was not successful. One embryo remaining. Do you suggest another retrieval? So, it would be my third retrieval. I only had 5 day 3 embryos last time. So, what I think the answer to that is people will often say, should I do another retrieval? And so the question that I will ask is, well, what's your goal? How many kids would you like to have? And the answer to that, most people will say, I will be very happy at this point just having one child. We just please bless us with one child, and then that's, we'll be okay with that. But if your heart tells you, if you kind of went into the process thinking, we would like to have 3 kids. Well, in reality, then let's say that you do a transfer next month. You do that transfer and then you get pregnant. Well, realistically, it's going to be, a year and a half or so before you can do another egg retrieval. And the difference in egg quality between now and a year and a half from now can be very substantial. So if that's the situation, then strongly, I would recommend you want to think about doing another egg retrieval before you do that transfer. If you say, well, we would be very happy with we'd be okay with one kid, and that's really what we're after here, then I would say go ahead and do your transfer, because if you get pregnant with it, problem solved. And if not, then you've only delayed another egg retrieval by 1 month. And so hopefully that's helpful there for you, Crystal. Hey to 26 Floor. I like that name. That's a good one. First appointment June 12th, all the way from Florida. Well, I'm all the way from Florida too, Neshia. Let's see. Oh, is that Allison Moore? The Allison Moore? Hello, if you're still there with us. Let's see. Will removing my tubes because they have fluid lower my AMH? Is it better to have them clamped to minimize the risk of lowering AMH?
So typically, no. Removing tubes does not lower your AMH. We're not really messing with the ovary. So removing the tube should not have a big impact at all on your AMH. I would not recommend, and I think Dr. Fink has the same kind of thought process, I wouldn't recommend clamping them. It's honestly better just to have the tubes removed. If those tubes are left there, fluid can leak back into the uterus and be toxic to an embryo. My advice is always to remove those tubes if there's a hydrosalpinx or a dilated tube with fluid in there, and I think you have the same.
Surgically, it's pretty straightforward to remove a fallopian tube, and when the tubes are full of fluid, that fluid is toxic to an embryo, and so we don't want those fluid-filled tubes or a hydrosalpinx to be there. If you have had multiple surgeries such that you're going to have a lot of scar tissue on the inside, then clamping the tube is an option. But one of the concerns is there that then if it starts to cause a pain syndrome, because you've got a blocked tube that may be swelling against the clamp, then maybe you're going to end up having surgery anyway. Now, back in the day when we did a procedure that was called Essure, which was basically a little rod that would go inside the fallopian tube, and it was a means of permanent sterilization, then we would sometimes do an Essure procedure in that situation. So the little rod would go in, the tube would scar over it, and therefore it would be blocked. But that procedure is not available anymore. I do agree, surgically, in most cases, it's just as easy to go in and remove the tube. If you know that you have a hydrosalpinx, always want you to think about doing the retrieval first before you get the tubes taken care of, because the earlier we are when we get the eggs, the better off we're going to be in terms of egg quality. All right, so hopefully that makes some sense to you. Let's switch over here to CNY's Instagram, and that is, oh no, actually that's my Instagram. My biggest fear, I did get COVID at 8 weeks and have a history of loss after COVID, on immune 2 protocol now. Would you recommend Paxlovid and stop prednisone? Not sure I understand the question. So you are pregnant now, it sounds like, and you got COVID while you are pregnant. Paxlovid can be taken during pregnancy. And I would say it's certainly worth talking to your OB about, especially after that history of the loss. Arlene is with us today. How much progesterone days is enough in a modified natural FET for a 5-day embryo? So with a day 5 embryo with a blastocyst, typically in a modified natural, you want to, just for those of you who don't know what a modified, are different types of embryo transfer cycles. We have medicated cycle, we have a modified natural, we have a natural cycle. So tell us about a modified natural.
So I've started explaining these a little bit differently just because it helps people to understand a little bit better. So in a natural or a modified natural cycle, you are ovulating. So usually I tell people this is an ovulatory cycle. In a medicated cycle, you're not ovulating. So I just tell people this is a non-ovulatory cycle. A lot of times I feel like people think, well, it's natural, so clearly it's better. Everyone responds differently to different protocols. And so one you're ovulating and one you're not. With an ovulatory cycle, I've had a lot of patients, and we've had a lot of patients message in and say, hey, I've ovulated. And last time I ovulated in a medicated cycle, my transfer got canceled. And this time they're not. So, I'm confused. So in a modified natural or in a natural cycle, we do want you to ovulate. So you grow an egg. As that egg grows, it puts off estrogen. And estrogen grows the lining. So instead of giving you estrogen, your own estrogen is growing that lining. And then once you ovulate, sometimes we use a trigger, sometimes we don't. You'll ovulate, and then the little follicle that egg leaves behind turns into a corpus luteum and starts producing progesterone. So in an ovulatory cycle or a modified natural cycle, you produce your own progesterone. So all we have to do is supplement with vaginal progesterone. In a medicated cycle, we're using estrogen to grow your lining that you take by mouth. So you're not ovulating, and then we have to completely replace your progesterone with the PIO injections and then the vaginal suppositories because there's no corpus luteum left behind to produce progesterone. So one, we use a little bit more of your hormones. The other, we do use medications. Some people respond better to their own hormones. Some people respond better to, pills that we give you. It just kind of depends. There's advantages and pros and cons to each different one. But yeah.
So how many days of progesterone? So usually you get, I'm not sure how much progesterone days. Usually it's, I believe the transfer is 6 days after trigger.
120 plus or minus 3 hours, unless
modified natural. Yeah. Okay. And Dibonese says, how soon after delivery can I do another transfer? How do you answer that question?
Typically I say, and I feel like everyone gives a different answer to this. I tell people if it was a vaginal delivery, 6 months. If it was a C-section, 12 months minimum. Some people say less, some people say 18 months. I would at least say 12 months minimum and be done breastfeeding.
Done breastfeeding, I think, is an important part of that. I usually tell people about 9 months because, again, the only preventable risk factor for severe preterm birth is a short interconceptual interval. So if, we really don't want you pregnant right away after having a baby. So, I would say it's probably something to ask your OB about. When would you like to see me pregnant again? We will certainly do it at 6 months. Just don't want you to do it too soon. Not a good plan in that regard. Coco Fitness, hello. Does removing a dermoid cyst at 5 centimeters reduce one's AMH? So a dermoid cyst is a type of growth in the ovary that actually began when you were in utero. And as you grow, oftentimes so does it. It contains a bunch of different types of cells. On the inside, these big cysts can have hair in them. They can have teeth in them, and they're full of a fatty-like substance. And so when things get to about 5 centimeters, we always think about wanting to remove them because that's the size at which we start worrying about an ovary twisting on itself, which is called a torsion. An ovarian torsion is considered to be a surgical emergency. It's something that can cut off the blood supply to that ovary. It causes very, very severe pain, and usually there's no mistaking it. So 5 centimeters is a good number to think about, hey, you should have surgery on a cyst. Anytime we do something in the ovary, we do run the risk of diminishing the AMH level. So yeah, I'm afraid that that may have some effect on the AMH. CDSNA5, retrieval of 3 eggs, 43-year-old, best to do a day 3 freeze or PGT. Worried not to do PGT because of age. We had 1 embryo before that was PGT tested and aneuploid. So, and I see a couple of tests over here. Liliana on the Facebook side saying, do you recommend PGT testing? I am 43. Also got my results back. 1 came back abnormal with a particular abnormality. I'm feeling lost. Is there anything I can do to improve egg quality? So how do you counsel folks about doing PGT? Do you think it's something that is related to how old they are at the time of retrieval?
Yes. So this is, an age and egg issue. You'll find that so many people will have opinions either way, and very strong opinions. Some people are very pro PGT. Some people, are not. Really, I try and just educate people and give you kind of facts about it, and then you can make the decision and form your own opinion. So, and I actually have these written down because I answer this all the time. So at 43, the chances of a live birth from a blast embryo, meaning a day 5, 6, or 7 embryo, is about 5%. So if you transfer a blast embryo, the chances that will be a live birth is 5%. So once you start entering that realm of 5, 3, 1%, there's no difference in doing IVF other than just trying at home, unless you do PGT. Now, with PGT, if you get a euploid, meaning a chromosomally normal embryo, the chances of live birth with a euploid embryo or a normal embryo is 65% on the first transfer, 88% on the second transfer, and a 95% chance of live birth on the third transfer. So normally my biggest advice to people is try and bank 2 to 3 chromosomally normal embryos per child you want before moving on to transfers. But if you want 1 child, you may say, I just want to do a transfer. The other thing that, to think about is people say, well, PGT is expensive. Well, yeah, but so is doing a bunch of transfers. So you have to kind of pick, what is worth it to you. Do you want to do transfers? Do you want to do a PGT? Are you trying to bank for a family? And not only, the physical and financial burden, but there's emotional kind of tool with transfers. So I think, deciding what's important to you is kind of a big thing, but those are the statistics. I usually tell people that, and then you can make a decision based off of that.
In my opinion, I would say, yes, it's true that, let's say at 43, you're going to have more likely abnormal, or what we call aneuploid embryos. One fear that people have is, well, that means that you're going to transfer this embryo into me, and then I'm going to have an abnormal baby. And usually that's not the way it happens. Typically in IVF, an abnormal embryo doesn't implant. So it can implant and can result in a miscarriage, but it would be very, very unusual to have a chromosomally abnormal live birth resulting from IVF. So the concern is not so much, well, you want to make sure your embryo is normal so you don't have an abnormal baby. The concern is, well, we can use PGT to narrow down the group of embryos that have a greater possibility of getting us pregnant. So that's kind of how I think about it. I do not think it is something that is necessary based on age alone, even though getting a normal embryo based on age, as Brandis just said, dramatically increases the odds of a successful pregnancy. So let's see. I'm gonna come over here and look at Brandis's. I can't really see it too clearly because it's very small. But I did see one little good bit of good news. This comes from M. Galaviz. No question. Just wanted to say thank you both. 9 weeks and 5 days today.
Oh,
God, that's awesome.
congratulations.
Thank you so much for sharing that. Let's see. RX, it looks like Ramirez, I believe that says, I was on birth control for 6 years and I took my IUD out in September of 23 and I haven't gotten any luck. So, one of the things that we know about birth control is that birth control does not have a long-term effect on fertility. It absolutely has a short-term effect on fertility, and that's one of the reasons we use it, because it stops you from getting pregnant until you are ready to be pregnant. Even the presence of an IUD, depending on, sometimes people who are on birth control pills, when they stop taking their pills, it may take a couple of months for you to kind of get back into having a normal cycle again. So it can stick around like that, but pretty much the reason that you take a birth control pill every day is because if you stop taking your pill today, you will go back to normal tomorrow. So it's a daily dose. With the IUD that goes inside the uterine cavity, IUDs these days are extremely effective and very, very safe. It would be very unusual to have any sort of long-term problem arising with getting pregnant as a result of using an IUD. So, normally what we tell people is that if you're under 35, 12 months of trying to get pregnant, after which it's a point that you start asking for help. If you're over 35, then usually we say 6 months of trying. If you haven't gotten pregnant, it's time to ask for help. So thanks so much for your question there. Something to add?
I'll add to that too. So something to keep in mind, either with long-term birth control pills or with IUDs, hormonal IUDs that can thin the lining. Sometimes it can take up to 3 months for a cycle to come back if your lining is super thin. If it goes past 3 months and you're still not getting that cycle back, kind of good indication, come in for an ultrasound or blood work to kind of see what's going on. And a lot of people forget this, but try and think about what your cycles looked like before you started any sort of birth control. If they were abnormal before, we think, okay, what else was going on that maybe the birth control was covering? So oftentimes when people come off and have these symptoms, you get a lot of Instagram people saying, oh, you have post-birth control pill syndrome and all of these things, when really you're just returning to your baseline. So that's important to note as well.
And I would see that kind of it's a very good point. Two different types of IUDs, by the way. So there is a hormonal IUD, which thins the lining, and there's a copper IUD, and copper functions as a spermicide. And as Brandis said, when that hormonal IUD comes out, it may take a little time for that lining to grow back again. And we'll see a lot of folks who maybe are 28 years old, started on birth control when they were 16 because their cycles were irregular. And then they, were put on birth control in order to regulate those cycles. And then 12 years later, they come off and their cycles are irregular. And they say, look what the birth control did to me. And it was actually what being 16 did to you. Just never went away. Mandy's here on the Facebook side. What are the estrogen and progesterone levels and follicle sizes we're looking for in order to trigger during a modified natural transfer? So first of all, what do you think about estrogen levels in those natural cycles?
This is the nurse's favorite question to ask me because they always come up to me and they say, I know you don't care, but so estrogen levels, especially when you are, and this goes for frozen transfers only, not fresh, estrogen levels, especially when you're on letrozole, will be low. That's how estrogen that's how letrozole works. So in a modified natural or a natural, I think our guideline for estrogen is 50. I don't know because I don't care.
We're the only 50. We're the only practice I'm aware of that tests it, and it really doesn't matter.
Yeah, the goal of estrogen is to get the lining to at least 7 millimeters in trilaminar. So for some people that takes an estrogen level of 1,000. For some people it takes an estrogen level of 20. Doesn't matter what it is. I just care about your lining. So yeah.
So the more important measure of estrogen is not what's the level in the blood, but rather what's it doing to your lining. And as Brandis mentioned, many of our sites, especially with a modified natural there, Mandy, we put you on letrozole for ovulation induction, and that's going to lower your estrogen level. So the number there is not important. Okay, so how about what size follicle do you consider to be mature, and what kind of progesterone level are you looking for?
So follicle size is hard because usually it's around 15 to 20 millimeters is what I'm looking for. I also not only want the follicle to be 15 to 20 millimeters, but I also want that lining to be thick enough. If for some reason you ovulate through meds, which can happen, then, we may adjust some things. But on average, 15 to 20 millimeters is the follicle size. And then I do want that lining, like I said, at least 7 and trilaminar. In an unassisted pregnancy, progesterone levels can range from 3 to 40 in pulses. So it's a range. Here, we try and give you a little bit of extra cushion. So if you're doing a medicated cycle, we keep that progesterone at 20. And then if you're doing a natural or a modified natural, it's about 10 to 12 that we keep your progesterone levels at. Yeah.
Awesome. Let's see. What is the cost of IVF? And that too is actually on the CNY website. People often ask us about costs. And when we're doing our consultations with people, one of the most common things I hear Brandis saying, and one of the most common things she hears me say, is that we don't know. Because we have nothing to do with the costs. We're kind of on the medical side. However, I will say that CNY Fertility is the lowest cost IVF in the country. And the costs are upfront. They are printed. They are listed out on the website. I think it is highly, highly unlikely that you will find that same courtesy in any other practice. Nobody wants to publish their IVF prices because in most cases they are pretty damned expensive, and they worry about sticker shock. So all that CMY pricing is available on the website, and I encourage you to go through, use that calculator, and learn that. Once you have a consultation with us, we send you are sent a financial welcome packet that further elucidates all of that cost of business there. So it's really kind of laid out in black and white, so talking about all the financing options and everything else. So please take a look at that. If you're already a patient, that's going to be in your portal. Veronica says, I did follicle scans. Everything was good. Now they saw fluid in my right tube and the left is partially blocked. Yeah, that can happen. And again, with that fluid in the tube, we don't want that there when it comes time to do an embryo transfer. His Queen Loving Me Keith. Isn't that a nice name? Good evening. Appointment is next month. Baby Mitchell loading. I like it. Let's see. Brene, you are asking, can you ask questions? Yes, by all means. Sheila is asking about prednisone. What are your feelings about prednisone and kind of in general about the immune protocols? Why would we use prednisone?
Yeah, so the thought, is that we're treating any inflammatory process that would keep the body from attacking an embryo. So a big thing, even in unexplained infertility, I tell people it doesn't mean, unexplained doesn't mean nothing's wrong. It just means that nothing we have a test for is wrong. And so by adding this immune protocol, we're treating things that either may come up positive on a recurrent pregnancy loss panel, any immune issues, or things that we may not even have tests for. It's kind of like prophylactic treatment. With prednisone, I do, I like it, especially for those with immune issues. I am not a big fan of people being on it long term. So if, you're taking a break in between transfers, let us know. Typically, I'll wean people off prednisone in between transfers. I think Dr. Fink does too, just because I don't think it's a great thing to be on all the time.
Not a good long-term medicine.
But yeah.
Yeah.
My 2 cents.
That's the 2 cents. Good. Hey, by the way, 35 minutes past the hour. We're going to be here for another 25 minutes. This is Fertility with Fink and Friend. My name is Dr. Randy Fink, and this is Brandis Montez from CNY Fertility, Colorado. And we sure are glad to have you here. Got lots of questions. Let's see what we can do to try to get to everybody. Amy G. Jess says, we're planning on PGT testing our embryos because of being 36 with PCOS. If I only get 3 to 4 embryos after retrieval, do you recommend freezing at day 3 instead of pushing to blast for PGT?
Again, very personal choice. We do have something called CNY protocol that kind of helps people to decide if you can't. So the CNY protocol is if you get 5 or more embryos, we recommend pushing to blast 4 or less day 3. I'm a fan of pushing to blast just because I feel like I like data. And so the more data I have, these were blast embryos, these were PGT tested embryos. I like data. So I would say push to blast. Again, it's a personal choice. It's up to you. You need to go into this with the knowledge, knowing that if you try and grow to blast, you may lose some. I do recommend PGT, especially in circumstances of recurrent pregnancy loss, unexplained infertility, or if you're trying to bank for multiple children. I like PGT, so that's kind of my 2 cents. And then I gave you the statistics before on kind of PGT versus not PGT. But at 34, the chances of that resulting in a live birth without testing at day 5 is about 40%. So take with that what you will.
Shabnam is here, and after a positive beta test, how long can you take tacrolimus, and does it affect the fetus? So this is a newer finding, and if you've been with me for the last few weeks, you may have heard me talking about that medication called Prograf. Generic is called tacrolimus. That is been shown to have a very, very significant impact on folks who have had recurrent pregnancy loss and recurrent implantation failure. Now, meaning to say that you've had some transfers that really should have worked but didn't, or you got pregnant, had a series of biochemical pregnancies, or recurrent miscarriages. When used at 3 milligrams per day, which would be either 1.5 milligrams twice a day or 1 milligram 3 times a day, it very substantially increases the pregnancy rate in these folks. So we have extrapolated that and have now recommended that folks start using tacrolimus even without that history, so that maybe we can avoid that history. And over the last, probably month or so here at CNY Colorado, we've been encouraging that use for all our folks having embryo transfers. I suspect that we are going to find that the pregnancy rates do go up. Now, is there evidence to show us yes, this is something that is important for the general population? No, but given that it is helpful for those who have had recurrent pregnancy loss and recurrent implantation failure, we believe it is something that is beneficial, potentially beneficial for everyone on some level. How long can you take it? We would generally recommend that you take it through the first trimester. It is not harmful to a pregnancy. The drug was originally came up with a study when they gave it to women who were having who had kidney transplants. And if you know anything about kidney transplants, these patients aren't always the healthiest. They've got, chronic medical issues, but they may be of reproductive age, so they can still get pregnant. They get pregnant, they've got these chronic issues, and so you would expect them not to have as good a result with their pregnancies. But there was a group of these people who were having great results in their pregnancies, and they looked to see, well, why is that? And it turns out it was because of that medication. So there are some situations where we would keep you on. There are folks who may have had 16-week losses or 19-week, ruptured membranes or severe preeclampsia. In that situation, you would stay on it longer. But otherwise, I would say 12 weeks, Shabnam, is probably a good time to stop. Oh, and how weird. I guess Felicia's here. We were talking about dermoids. She said, how weird we would talk about that today. We just found a mass on my left ovary. Well, hopefully that turns out to be nothing serious. Rachel asks, I'm having a transfer on Monday morning. We will look forward to seeing you. Should I fly in Saturday for the HCG wash, or a mini shot of the HCG in the morning is enough? What do you think? We have strong opinions about that. And I saw that there were a couple other questions about the HCG wash. So how do you counsel people about HCG washes?
Yeah, so I'm pretty sure you mean HCG wash, not a shot. So this is a uterine wash. I like it 24 to 48 hours before, not the day of. And the reason is because I don't want anyone, putting any fluid in the lining on the day of transfer. And I don't want anyone else sticking anything in the uterus and the lining the day of transfer. I would like, well, either mine or his catheter to be the only one in there on the day of, just because it does, it can lower chance of pregnancy to have any fluid in there or lining to manipulate it with. So 24 to 48 hours before.
There's been a lot of talk about, so yeah, we do believe, what does an HCG wash do? HCG is, of course, the pregnancy hormone. What does it do? It turns up the volume knob on some of those receiver proteins inside the uterine lining and may improve that embryo's ability to implant. There's been a lot of talk about using a mini dose wash of that HCG on the day of transfer. And what Brandis is referring to is that very thing. We do not believe in it. We feel pretty strongly that you should not do it. There was a small study that looked at it that, when done in a very strict fashion, was thought to improve some pregnancy rates. However, when actually studied at CNY, we found it did not improve the pregnancy rates. Rachel, I'd really rather you not do that if you can. Kayla is with us on CNY's Instagram. 4 failed medicated transfer with tested embryos. I have endometriosis and PCOS, had a hysteroscopy, did Orilissa, would love to know what you recommend. So first thing there is the endometriosis. So you know that you have endometriosis, you did suppression of that endometriosis. That's probably the most important thing. But if you had 4 unsuccessful transfers of genetically normal embryos, you absolutely fall into that category for the use of the Prograf. I think that article was written just for you, just for that kind of scenario. Suppressing endo, very important, but I would also 100% add Prograf, 1.5 milligrams twice a day. Veronica here. I really hope you come to Texas. Well, were you invited to Texas? I didn't get invited to Texas. You hope we can. Well, we're waiting for the invitation, Veronica. All right. It looks like Meg Marnell has joined in. Meg is the director of the OR operating room services for CNY Fertility and lives and works in New York. Leroy is here. Leroy and Emily B, it looks like. Looking forward to meeting you both soon. You're on STEM Day 6, hoping to get to Colorado for retrieval. Fantastic. We are happy to have you here. Noreen says, if I plan to do IVF in June, do I need to be taking priming meds in May? Well, there are some priming things that I think everybody can do specifically for egg quality. And there is a list of supplements, and that is a good segue to say, if you will go to my link tree, which is linktr.ee, linktree/Randy Fink MD. And if you forget that, it's the link in the bio on my Instagram page, Randy Fink MD. I've written an ebook about that list of supplements. CNY also has some wonderful supplements through Molecular Fertility, and that's molecularfertility.com. I think everybody should be priming on the evidence-based protocol for egg quality, 100%. There are some other priming mechanisms sometimes we will recommend for our patients, not all the time. So if it was recommended for you, then yes, for sure. If it wasn't, there may be a reason that it wasn't, but certainly that is worth asking a question through the portal to your respective team. Should I, priming was not discussed in my original consultation. Should I be doing some priming? Mrs. Ann Smith said, I just lost an ovary because of endometriosis, and I'm worried that I might not get a lot of eggs when it comes to the retrieval. What can I do to have a better outcome? Well, again, I think the supplement list is really critically important for 100% of people. But I will tell you also that it's very frequently we have folks who will come in who have one ovary for retrieval, and they do very, very well with IVF. And I know it's one more thing for you to have to lose sleep over and worry about, but I would not lose confidence in that one ovary's ability to get you a child. In nature, let's say you weren't doing IVF, having one tube does not decrease your pregnancy rate by much at all, and having one ovary doesn't really affect you in terms of hormone levels, and it may lower your AMH a little bit, but it gets you no quicker to menopause or anything like that. So Mrs. Smith, fingers crossed. Natalie Foster is here. I had a hysteroscopy in February and I'm supposed to transfer on May the 6th. Yesterday's ultrasound showed some fluid, so Mucinex was added to the plan. Enlighten me on this. Never had it before. So you want to handle that one?
Yeah, so the thought is that Mucinex dries up fluid. So oftentimes it works to dry up fluid in the uterus the same way. Usually I will, if we do a lining check and somebody has fluid in the lining, I will have them add Mucinex if this is an issue kind of in the clinic. Then we'll add Mucinex, or if we do, a wash and there's a ton of fluid in there from before, I'll just say, hey, take Mucinex for a couple days and then come back. And actually, I don't think I've had anyone come back and still have fluid in their lining after taking Mucinex, so it really works. I don't know if you've seen any different.
It does dry up that extra fluid. What's that fluid there from? Well, sometimes it's a little blood that's sloughing off. Sometimes that lining gets a little raw, and it's a sign of maybe, almost like you skinned your knee, but you skinned your endometrium. And so that's really the reason for it. And most of the time it actually does work pretty well. David says, oh gosh, David is obviously very smart here. Dr. Fink is the best doctor. What are you laughing at?
I knew he was going to read this.
I had to say
it.
The
second I saw it come up, he was not going to skip you.
He did my, oh gosh, this is awesome. He did my wife's retrieval and transfer a couple of months ago. With your help, she is pregnant with the first transfer. God, we love to hear that. Thank you, David, so much for saying such nice things. Megan said, looks like Megan Downey tried IUI once and it worked, resulting in a healthy embryo. Would you recommend IUI again or go to IVF? I think it depends really, Megan. So IUI gets you in general about a 9% probability of pregnancy. IVF can get you up to a 65% probability of pregnancy per embryo as opposed to per cycle. So if IUI worked, I say there's no harm in doing it again. Where I think harm comes is when folks are doing IUIs maybe I do a consultation and we set up for an IUI and then I don't see them again. And maybe a year later, I look and see that they've done, 11 IUIs. And that makes no sense to me. When IVF is going to be so much more effective an intervention. In my heart, I feel like, after 3 IUIs, it's kind of hard to want to keep doing IUIs when we can offer you so much better an outcome. And cost being what it is, if you're at a place where IVF costs you $25,000, you're going to do everything you can to not have to get into that $25,000 cycle. But at CNY, where it's $39.95 plus the medications, before long, you've spent more than you're going to spend on IVF. In my heart, the data shows us that after 5 IUIs, you're no more likely to get pregnant than you are with home intercourse. But I kind of feel like after 3, it's time to step it up and maybe try to do something else. Just my opinion. Ariel says, I have a 2-year-old from the Colorado office planning my 4th transfer for a sibling. Thanks for the rainbow baby. That is awesome to hear. That's awesome. 2 quick questions over here I want to hit on the Facebook side. Allie is here with us. Had a retrieval, Dr. Fink on 4/16, and Brandis, you did the transfer a couple days later. You're both awesome, and you are our best friend now. Absolutely. Love the Colorado office. Unfortunately, found out yesterday that the transfer was not successful. Do you recommend trying a frozen embryo transfer right after a failed? Is there a higher or lower success? Do you change the protocol? There's still a lot of medications. There's still a lot of medications with just a transfer. I know that's a lot of questions, but hoping for an answer. All right. Well, so there's no data that shows us that you're either more successful or less successful going right into another embryo transfer after an unsuccessful transfer. So given that scenario, it didn't work. And it looks like you did, Allie, you did a fresh transfer. Fresh transfers are included in the price, but they are not as successful as a frozen transfer. There are a couple of different ways that we can do frozen embryo transfers: medicated cycles and natural cycles. Natural cycles have a lot less medication. There are the immune protocol things that we like to add. So I would encourage you to go right back into it. Sometimes you need a little time emotionally to kind of recover from it. Sometimes financially, it may take a little extra time, but a frozen embryo transfer is a lot easier than doing an egg retrieval, for sure. Emma has a question here, and I want to address this. Currently 9 weeks and 2 days pregnant, thanks to CNY. That is so awesome. Never had a pregnancy before, and I'm worried about stopping my PIO and the estrogen medications at 10 weeks. Can you give me some reassurance?
Yeah. So so you did a medicated cycle. And so we gave you estrogen to grow that lining. And then once it was thick enough, we replaced your PIO because you didn't have a corpus luteum. So in a natural cycle, or in an unassisted pregnancy, that corpus luteum will produce progesterone in pulses. So LH comes down from the brain, tells you to ovulate, and then LH continues to come down in pulses to stimulate that corpus luteum to produce progesterone until around 9 to 10 weeks, when that placenta, what's called, rescues the corpus luteum and takes over, and then that corpus luteum will die off. And so then the placenta will take over, and so it's not coming from that corpus luteum anymore. So we are replacing that progesterone with PIO, and then at that 9 to 10 week mark, that placenta should take over, because that's how it works in an unassisted pregnancy. That corpus luteum will die off. And so at that point, we don't need to kind of replace that progesterone anymore, because that placenta is going to take that over. So that's a very common thing I get on questions on Thursdays on my Instagram on, hey, I'm really scared to stop this. Totally normal feeling, but at this point, placenta knows what to do.
Placenta knows what to do. It takes over at about 9 weeks. We continue on that hormone for a little bit longer, but I think you should feel confident that you're going to be in good shape there. Looks like Brad is asking about, do you recommend laparoscopy and excision for endometriosis before an egg retrieval if previous egg retrievals weren't great and transfers failed?
You're going to get a different answer, I feel like, from everybody. I do not. I actually typically don't recommend laparoscopy for fertility purposes only. If you're having pain or other symptoms, by all means, I would recommend that. But for fertility purposes, if you're having failed, and this is kind of the key, if you've had failed day 3 transfers, it's kind of hard. If you've had recurrent implantation failure, with normal embryos, then at that point, I would recommend doing the hormonal suppression. Different ways, Lupron, Myfembree, or Alyssa. There's a bunch of different options, but I typically don't recommend laparoscopy with excision just for fertility purposes. We have really good outcomes with hormonal suppression as well without surgery.
Very much so. And now we can also diagnose endometriosis without surgery, and that's through the test called Receptiva. And if you'd like to read about Receptiva, that's their website is receptivadx.com. Low AMH and diminished ovarian reserve and 40 plus. Do you recommend mini IVF? So mini IVF is just a choice to use a lower dose of medication. The classic wisdom with lower AMH was that we would want to pour as much medication on your ovaries as we could in order to try to get you to respond. What we've learned is that those higher doses of medication may not be successful in doing that. Sometimes the ovary doesn't know what to do with all that stimulation, and so it doesn't really do very much. What we've learned is that when we use a mini dose therapy, we can get a lot of things from that. One, we're using a lot lower a dose of medication, which means that there's a lot lower cost and lower side effects. And when we lower the dose, we end up getting really the same kind of outcomes as we would get with the very high dose therapy, sometimes even potentially better. So one of the best uses of the mini dose is in folks with a diminished ovarian reserve. So it looks like CHOP and Guardians. I can't tell what that says, but forgive me, it's my glasses. But yeah, I think that a mini dose is not a bad thing. Do you give prednisone and estrase to bring on a period if needed? Well, we would actually use progesterone, not prednisone. Estrogen, typically you don't need unless you're not making enough estrogen of your own, but that's one of the ways to be able to bring on a period. Is it possible to help if your FSH is high? Yes, because, and we want to be able to do that because the medication that we're giving you for IVF is FSH. So we would like to try to bring that down, and usually we can do that by giving you a certain form of estrogen. Yeah, we usually would. I like the FSH to be 15 or below before starting an IVF cycle. Christina is asking about the MTHFR gene mutation and how it affects fertility. What can you do to combat it? Well, MTHFR is methylene tetrahydrofolate reductase, and that is an enzyme in the body that helps with your metabolism of folic acid. You really just need folic acid, and I think the best choice for that is what's called methylated folate in your prenatal. Still, that is all the folate you need. We used to think that that had something to do with recurrent pregnancy loss. It is no longer considered to be really a big impact on pregnancy, but folic acid, probably the most important vitamin in all of pregnancy because we know it decreases the risk for neural tube defects, which are things like spina bifida, similar spinal type birth defects. Folic acid, it's recommended 400 micrograms a day for everyone for at least 3 months prior to conceiving. If you take a prenatal, there's usually at least 800 in there. And if you're on a prescription, there may even be more than 1,000 or up to, that's a milligram of folic acid. Some people want to take extra folic acid, and you really don't have to, as long as you're getting that minimum of 400 in your prenatal vitamin, then you are getting sufficient folic acid. But in the case of someone carrying the MTHFR gene, methylated folate is probably the best bet. Is 9 follicles good? What can you say to ease my mind? Equestrian is coming on Monday for an egg retrieval. What do you think of 9 follicles?
I think 9 follicles is great. And I think a lot of people, focus on, you're having me answer a lot of controversial things.
I'm not answering them. Yeah, right.
No one come for me. A lot of times the count we get in there, sometimes there's more.
Completely different than what it was in monitoring.
Sometimes, some follicles have eggs, some don't. Sometimes we put the ultrasound in and it's 9, there's 25 eggs here, or 25 follicles. So I wouldn't get too, set on a follicle count, but yes, 9 is a great number. And it's important to know, quantity or quality over quantity. So the goal is to get, good quality eggs. So if you have, 9 good eggs, that's great. So yeah.
And I always tell people, I don't care what they told you have at the time of your during your monitoring, because when we look at it, it is often completely different than what they said. Try to get one more question here. Is having my tubes tied and burned going to reduce my chances of successful IVF? That comes from Ms. Perfect. What do you think?
No. So that's actually a big reason people do IVF. So we don't use tubes at all for IVF. So normally when egg and sperm meet in the tube, in IVF, they actually meet in the lab. And then we put the embryo straight into the uterus without tubes at all. So it does not reduce your chances of having IVF. That is actually a big reason why people do IVF. So hopefully we get to see you.
And whether they're tied, burned, stepped on, cut, what else? Rubber banded.
Unless they're salpinxed, then those need to come out.
Talk too aggressively. IVF is still your choice after tubal sterilization. I am afraid we are out of time. Boy, the time flies by so fast. Hey, keep your eyes on Brandis's Instagram, which is Brandis Courtney. Every Thursday, when do you answer your questions? She open source or open mic for questions on Brandis's Instagram every Thursday. So please feel free to reach out. I do it sometimes. She does it much more reliably. As always, so nice to have you guys here with us on a Tuesday evening. Brandis, thank you so much for being with us.
Yeah, it's been fun.
It's a pleasure to have you here working every day, and even nicer to have you here on Fink and Friends. Every step forward is one with kindness, because life is too short and there are not enough kind people in the world. So do your part, would you? Every step forward with love, and every day knowing that tomorrow brings new things. There is hope for tomorrow. Have faith in that hope. This is not the journey. This is just a journey. It is not the book of your life. It is only a chapter, and we're here to help you rewrite it. So until next Tuesday, I'm Dr. Randy Fink. Thanks for being with Fink and Friends. Good night.